So, in the last lecture we talked about how without technology, using your brain, as I said in the introduction to basis of behavior, is that the best person to know and study the brain is you, if your mind and somebody else's mind. So, mental status examination, as I delineated in the last lecture, last two lectures, is essentially a way of understanding the other person. Now, once you have understood, once you have looked at the phenomena, and once you have understood that why these phenomena have been called abnormal, how do you decide at the end of it that whether it is normal or abnormal? So, before I come to that process, I would like to quote Khalil Gibran, who says, "I have found both freedom and safety in my madness, the freedom of loneliness and the safety from being understood. For those who understand us, enslave something in us." He essentially says, how do you decide what is mad and what is free? John Nash, we all know, on whose life Beautiful Mind was made, and he died an unfortunate death by an accident. And the film like One Flew Over Cuckoo's Nest, all these life stories raise a basic question: what is a patient and what is a person? Even if you know phenomenology, all that phenomenology has been derived from labeling something as abnormal, something as normal, some thought process beyond a certain threshold based on morbid basis as delusion, something as a hallucination, but these are experiences of human mind at the end of it. Maybe the disruption caused by anybody is abnormal, or if the person is not causing any disruption and is just living in his own world is abnormal. So, how do you decide what is a patient and person? What is abnormal? And this is a whole list of words which have been used: insane, lunatic, abnormal, mad, bad, mentally ill, and I do not know what will be the future terminology used for all these people who are exhibiting so called abnormal behavior. The words which have been used, the treatment which has been meted out to them has been changing according to the context, country. They were put in prisons. First they were you know, they were burned at altars, they were exorcised, they were put in prisons first, and then they were released from the prisons, and mental hospitals were made for them. Now, it is ongoing debate between philosophers and anti-psychiatry movement. So, on one hand, we practice psychiatry according to the laid rules and the systems and the labels which we have created, and on the other hand, the society and internally we all keep questioning. So, this is the paradox of human life, which maybe will get resolved in future. But even if we are able to look at the cause of illnesses, we still define illnesses from the external factors. In the sense, what is normal? Is normal what is statistically normal? You look at the IQ range, take intelligence for that matter, the Gaussian distribution, bell shaped curve, IQ 100 is average here, and IQ 2 standard deviation, 1 standard deviation, and you distribute the whole population. But this we know, it was shown to, this data was used for exploiting people for the racism and for separatist thing. So, what is normal? Is it what most people do is normal? By that standard, even Mahatma Gandhi would be abnormal, because we all know his life, but he was not. So, by a broad consensus, by statistics, by various studies all over the world, and seeing people how they behave, most people behave and how some others behave, how group of people behaves in their context. This is a broad definition of mental health. It is not just the absence of mental disorder, it is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses, can work productively and fruitfully, and is able to make a contribution to her or his community. Now, this, if you say, is normal, and any deviation from this is abnormal, for functional purposes, let us assume it is. So, what are disorders then? They comprise a broad range of problems with different symptoms. However, they are generally characterized by some combination of abnormal thoughts, emotions, behavior and relationships with others. So, any disruption in thoughts like way the other people are thinking in their context, or emotions or behavior and relationship with others, but still having said this, it is still very complicated and it is still convoluted. So, it is difficult to decide what is it. Is it a continuum from normal to abnormal? Whether everybody what abnormals have, say in a higher proportion, normal people have in lesser proportion. So, it is a range from healthy to adjustment disorder to minor illnesses to major illnesses. Is it this, or it is discrete, that mentally normal people are different people than mentally abnormal people. They have a different set of thought process and these people have a different set. It is still debatable. Now, by phenomenology, if you go, you will say abnormal people have something which these people do not have, but delusions can go from a thought, hallucinations can come from a perception. At times, we all have our internal imagery, whether imagery is different from hallucinations is difficult to decide. Imagery may have a will, hallucinations do not, but are they using the same pathway is a question which we still do not have an answer to. So, this debate as it rages, what we have done. So, whether we have again this big thing, is mental health defined by a unitary construct? It is not. As you said, relationships, emotions, thought, this complexity, social, career, relationships, ambitions, all things go on into deciding what it is all about, or it is context driven. So, if a certain person like Gandhi behaves in this context, it may be normal. So, whether we define mental health as a absolute objective construct and say only this is mental health, or mental health is a fluid concept which depends on the context in which it is being talked about. So, that raises another question, what is abnormal? Possible definitions: statistical deviation, violation of social norms, but not everybody who violates social norm is abnormal, because otherwise courts of justice would not exist. Subjective distress, whether the person is uncomfortable with himself, if that is the question of abnormality. Disability or dysfunction, somebody is unable to do mathematics, or somebody is unable to has a damage in the brain by which one is not able to find a way through. Abnormal behavior does not necessarily indicate mental illness. So, lot of abnormal behavior at times is temporary, as I said in the previous lecture. It may be just a context driven thing or a drug, under the influence of drug or alcohol, but that and person bounces back within a short span to normalcy. Now, what is that normalcy? Is his normalcy in his context. So, context again is very important. There is no absolutes in psychiatry right now, except for bearing very few things. So, what is the need for classification? The need for classification comes from to understand and communicate for clinical research and educative purpose. This is pretty clear. But there is a difference between psychiatric classification and medical classification. Medical classification is based on the cause. Even a group of symptoms which cause a syndrome, we take it in a trauma, endocrine, metabolic, electrolyte disturbance, infectious, cerebrovascular or vascular. So, these are essentially headings which are caused because of vascular disturbance, something has happened, because of infection something has happened. Psychiatry classification is not based on that. It is more experiential and descriptive. So, the classifications which exist in psychiatry like Diagnostic and Statistical Manual, DSM, and its various versions, and International Classification of Disease Chapter 5, they have categories based on the group of symptoms which have been pulled in from all over the world with various epidemiological studies and descriptive studies. The differentiation between medical and psychiatry is this, that these categories which we have formed in psychiatry decides the treatment approach. Like if there is a category of psychosis, we treat it with antipsychotics. There is nothing like this in medical, that is a category which has to be treated with antibiotics. Infection, yes, but there is no definite treatment for say vascular, there are other medicines. So, medical classification is based on cause, psychiatric classification, and that is a gap between medicine and psychiatry. Whether we are moving towards cause based classification is something which for next 20 years will tell us. But presently the diagnostic labels in are descriptive from the experiential mind state of the person, and these categories are correlated with the treatment blocks, the type of drugs, the group of drugs which are available. Now, it may sound very non-scientific, that is, it appears like a mix and match, that you have a category, you have a group of drug, depression, antidepressant, and is it totally subjective? If now we do not talk of subjectivity of one person, we can talk of subjectivity of groups which are describing this, but there is a savior. The savior is that epidemiology has shown that these descriptive characteristics exist in the world all across the culture. That means irrespective of where the person is, if you take a certain set of population, that much percentage will have anxiety, that much percentage will have depression, that much percentage will have schizophrenia, which may be coming from genetics, because we all have a common genetic pool. At least 74,000 years back, when the modern man started migrating from Africa after the destruction of this huge Indonesian volcano, very few people were left, and from Africa migration genetics has proven it very well. So, the risk of having illness is in all of us, because we know the common genetic pool, we know the common genotype with a very little variation, and that little variation causes illnesses. But the relative risk varies, like I may have a risk of 1% schizophrenia if I do not have anybody in my family, it may rise to 10% if there is 1% roughly, and epigenetics decides whether the genetics is going to express or not. So, as I said, medicine is symptoms, cause, treatment; psychiatry is symptoms, treatment, cause we still do not know. This is unlike neurology, where we go on, we can find causes of neurological illness to a large extent through imaging and other, right up to mitochondria in some cases. So, this is a cause driven classification, this is description and treatment driven classification till now. Maybe next 20 years of neurobiology and imaging and neurophysiology we may be able to give you the exact location and the time frame of when does the hallucination happen and why does it happen. Maybe we may be able to give you some a frame of network, that okay, disturbance in this network causes hallucination. So, but what are the etiology? Even if you look at it, nature, genetics, antenatal influence, nurture, parenting, drugs, neurological illness, biochemistry, psychological stress, all these are the etiology of psychiatric illness. What is the pathology? Sign and symptom, go on to make a syndrome, disorder, disease and illness. Here is where the disability factor comes in. So, we all know this, syndrome is a set of signs and symptoms that co-occur at greater than chance frequency. Disorder is syndrome with a clinical course. So, there is a syndrome which goes on, becomes a disorder. Disease is etiology, pathology, pathophysiology. Illness is where the disability comes in, the psychosocial aspect of being sick. So, mental disorders are broadly classified across all classification. If we pool in everything, broad understanding of mental disorder is either they are organic, where we can find out a medical or a substance, versus non-organic. Psychotic versus non-psychotic. Psychotic, as you remember, hallucination, delusion, lack of insight, loss of touch with reality, versus illnesses where the person is in touch with reality. If psychotic, with or without mood symptoms, or if it is mood symptom with or without psychotic symptoms. This is a broad classification we still function on, although the labels and categories are many. Severe mental disorders, which are less in number if we take a percentage wise, versus softer spectrum, which are emerging more and more. 30 to 50% of people in all clinics across all medical disciplines are people with psychiatric illnesses. Now, these people are having psychiatric illnesses primarily, or they are comorbid with other medical illnesses. We may call them, some people call them problems of living or social suffering, which are being medicalized, but that is a political philosophical debate. But anxiety, depression, situational depression, all this is part of software spectrum. Severe mental disorders obviously are schizophrenia, bipolar. So, this is now there are two other things, whether it is a categorical thing or a dimensional thing. Multi-axial system, the Diagnostic and Statistical Manual uses this. Axis 1 you have clinical disorders, the category and description of that illness, for example, panic disorder. Axis 2, so these illnesses a person is going normally, has a onset of illness which comes in axis 1. What has been continuous, say like a right from childhood somebody is behaving in a certain way and keeps behaving like a personality disorder, or say a mental retardation for that matter, developmental you can put, general medical coexisting condition with it. Axis 4 is about the environmental problems with support group, marital discord, education. So, this is the context of the environment. And axis 5 is global assessment of functioning scale. This looks at the disability level. Now, we should know what impairment and disability. Impairment is a dysfunction of an organ or a process. Disability is the dysfunction arising out of that impairment. So, a impairment does not necessarily mean disability. A person may be impaired, but he may not be disabled. So, what are the conceptual tensions in classification? Because this is also philosophical, and everybody says with that psychiatry, if they label people too much and whether they know how to diagnose, which are some of them are valid questions, some of them we still do not have answers. The conceptual tensions are phenomenology versus course versus etiology. Etiology means the cause, whether it is descriptive or theoretical, it is categorical versus dimensional as I showed you, symptom versus syndrome, reliability versus validity, whether we want to lump in too many things together or split them, clinical versus research purposes. So, what I was trying to tell you that there are two categories called, two classificatory system called DSM, Diagnostic and Statistical Manual, which is used by United States of America and other countries, and there is a WHO from WHO, which is called International Classification of Disease, which have categorical category, the categories. It is a categorical classification where you have description for schizophrenia, for mood disorders, where we have created chapters like psychosis and mood disorders. They are essentially descriptive. We haven't linked causes to it. On a multi-axial level DSM diagnosis and categorical ICD, but the debate still goes on because we haven't till now put down the basis of the cause. So, still is a match between diagnosis and treatment. So, we will in the next two lectures we will try to look at how beyond this mental status examination and after labeling, do we do any medical process or try to investigate in some of the patients about the causes. Thank you.